All right. You guys okay? All right. Hopefully that look all right. Kind of early in the morning today. So, Grand Rounds for Mentoring Functional Medicine. I'm Dr. Garrett. I'm your host for this. Today, I'm presenting a case number 8, which is a 58-year-old male with chronic pain. How many chronic pain people do you guys have, right? Like, that is the majority of people that come in America. 3 out of 4 are chronically managing chronic pain. And our goal is to figure out why and then not have chronic pain. So we'll probably have a lot of these cases through our time together. And these will be very meaningful one. I think it's maybe the consult every time we talk about how, or no, it's when we talk about in food is medicine, maybe the second visit, how patients come in, they'll just be like, oh my God, my knees are bone on bone. I'm gonna have to get them replaced. And then after about 6 weeks of making all these lifestyle changes and dietary inflammatory changes, then we're like, how's this doing? How's that doing? Like, how's your knees doing? And then always like, oh my God, it's a miracle. Like, which knee was it, doc? But it's not a miracle. We eat 40 times the inflammatory fatty acids as anti-inflammatory. So all that corn-fed chicken, corn-fed fish, corn-fed junk food, it all comes with a consequence, which is inflammation. So if the animal eats inflammation all day, and then you eat the animal, all its fatty acids are inflammatory, making inflammatory prostaglandins, which then there's 4 major outcomes. And the first major outcome is that you get more pain and inflammation. So in a country where we're eating 25 to 40 times more inflammatory fatty acids, of course, that's exactly what should happen. So, if you make that change, so like eating 1 serving cold water fatty fish like salmon, tuna, halibut, mackerel, cod, sardines, wild caught, that's fish, wild caught ocean fish, so like those. And then free range birds, and then grass fed, grass finished, no antibiotic meat. Well, that's just as effective as a full strength ibuprofen for getting rid of your pain without killing your kidney and liver in the process or causing a GI bleed. So then all of a sudden, you stop causing all this chronic inflammation, you start eating away inflammation, and then you don't have to manage inflammation, whether natural or synthetically. So this is a 58-year-old male. I would say probably chronic pain, we typically see both now, right? It's pretty evenly divided. So 9 years of chronic musculoskeletal pain, a lot of low back, cervical, and of course bilateral knee pain. Of course, the pain is disrupting his activities of daily life, his quality of life, reducing mobility, physical activity and exercise tolerances are lower now. So, he's 58, he should be still pretty active. Theoretically, he's a little over halfway there. But now, you'll see people now in their 30s with chronic pain like this, that's just changing their whole life. So our goal then is to get his whole life back. He has difficulty sleeping, especially, laying on their back, laying on their side, their shoulders chronically hurting, their low back's chronically hurting. We talked about how like your whole upper body is balanced on one little fluid disc in your low back sitting on your sacrum, so lumbar to sacrum. It's just a little bit of fluid. But most Americans are subclinically dehydrated, so eventually that disc starts getting lower and lower, and then those joints get a little sloshier, and then the nerves coming out of there start getting infringed upon, and very quickly it starts causing pain. So you have pain, then chronic pain, then paresthesia, then numbness, and then dysfunction. So it only takes about the weight of a dime to really kind of start affecting nerves. So we want to stay hydrated. People do decompression therapy with this, but the movement going around creates a pumping action that actually pulls water back into those disc spaces. So outside of decompression, where you just stretch the person, they need to be drinking lots of water and moving. And you guys know the formula for water? So it's half your body weight in ounces of water a day. So most people do not drink anywhere near that. And they drink a bunch of diuretics like coffee and beer and soda. and black tea, and so then they don't get water, and then they deplete more water, and then the body starts to dry up, and then you're going to get the natural consequence of low back pain, even cervical, and then your knees, your whole entire upper body is sitting on two bones in your lower legs, separated by a little bit of fluid. So should they have chronic pain if they're dehydrated over years? Yeah, and then they don't move, and so then it gets more inflammatory, like substance P soup in there, and then that starts to say, we got to protect this area, and the way your body protects you from pain is scar tissue and locking down and fusing joints. So when you have that decreased range of motion, and all of a sudden you're like, I can't get to the upper cabinets, yeah, you should, right? So that's why we always want to heal in range of motion, knock down inflammation with our diet, stop causing the inflammatory problems, and basically restore normal. So your body's constantly in a battle for restorative physiology with this. So this quality of life dramatically changes for them with pain. I think we've all probably been through some acute pain, and you know, like, okay, well, this is not cool, right? And then people like us are like, well, we should make some changes here, but everybody else, they don't know. They just manage that, right? So prolonged sitting, prolonged standing becomes an issue. Exercising, of course, becomes an issue, and especially purposeful movement, which is the most critical exercise. And of course, performing household activities and reduced activities for deconditioning. And of course, basically he's getting weaker and fatter because of that. And that persistent pain negatively affects his mood and social participation. So, of course, people in chronic pain are chronically grumpy. They're not getting sleep. They're constantly hurting. Nobody has great answers. And then they're just like, I got another 40 years of this. So you're going to change lives with this kind of stuff. Now, medication and dose is really just, again, COX-1, COX-2, PLA2, and really like not 5-LOX. 5-LOX is more for severe asthma, allergies, that kind of stuff. But for the most part, COX-1, COX-2, and PLA2 pathways, that's where you're going to see your main drivers for blocking pain and inflammation. And then when you can't do those anymore, well, then let's give you some morphine, right? But not real morphine, medication morphine, which is also highly addictive. And then the next thing you know, they are on crack. So that's a very common trend, and that's why they got sued, and nobody cares. But it's still a big burden. And we don't have great answers, right? So this guy came in at 58 with chronic ibuprofen, 600 milligrams 3 times a day, so 1,800 milligrams. Now, this is a COX-1 inhibitor, which of course is going to block really not much of the pain pathway, just a little bit. COX-2 is more pain, right? But COX-1 is a little bit of pain, but it also is what allows you to make mucus in your stomach. The only thing separating your digestive juices and acid from eating your own stomach and the rest of your body is some mucus, some slime in there, right? That's why your body makes 10 cups of mucus from your sinuses, drains all the way down, and then it helps coat that stomach too. But those goblet cells in the stomach are protecting you from eating yourself. So if we take a medication that blocks that production, you're going to get drier sinuses, so more upper respiratory infections. You're going to get a drier throat, so more kind of that eosinophilic esophagitis kind of feeling or lump in your throat. You're also going to end up with ulcers. Okay, now ulcers typically we think of like H. pylori overgrowth infections, secondary to antibiotics, but you're also going to start eating away your stomach. Now, when it hits a blood vessel, so the mucus is gone, it starts eroding a little bit of tissue. Once it hits that middle layer, hits a blood vessel, you start bleeding in your stomach, which is not a problem because then you have thromboxane that then clots. But thromboxane is regulated through the COX-1 pathway. So that ibuprofen is not only preventing mucus to protect you from your stomach, now you're actually blocking thromboxane, which prevents you from bleeding out. So now 70% of people with chronic ibuprofen use within 2 weeks will have a GI bleed, And this is why the U.S. Task Force really stopped recommending even that low dose 81 milligrams for anybody over a certain age, because you were more likely going to kill them with the side effect than save them from their pain. Plus, COX-1 is not a very big pain relieving pathway compared to COX-2, but COX-2 increases your risk of heart attack and stroke and affects your liver and kidney. So, it's robbing Peter to pay Paul, basically, when we're chronically managing. So 600 milligrams 3 times a day. Gabapentin is typically the next big one they go to for chronic pain, especially nerve pain. But gabapentin is GABA. So GABA in certain parts of your body, where the nerves connect to another nerve and the axon basically hits another dendrite. Well, GABA can shut things off, right? So like for sleep, GABA raises to suppress the brain and the neural functions. So then you have what's turning on what's called the reticular inactivating system. But in other places of the body, GABA actually stimulates, right? So much like glycine is a neurostimulatory and a neurodepressant, so is GABA. So we can't really mess with one place without affecting another place when we start inhibiting and blocking pathways like that. So there's consequences of that, of course. Gabapentin, I believe the brand name, one of them is Keppra, and one of Kepra's famous side effects is Keppra rage. So I had a friend that her husband has seizures. She accidentally took his medication instead of her medication, and she was just like, I just wanted to kill people all day. I was so angry. I'm like, can you imagine having to take that for life because you're in chronic pain? That would suck, especially for everybody around you. So gabapentin has some benefits for especially neuropathic pain, but it's also going to have consequences for where it's also suppressing the GABA pathways. Now, eventually they go to hydrocodone, acetaminophen. Acetaminophen is the number one cause of liver failure in the United States, so you can't be taking that for very long. When I was lecturing, maybe 2012 for the postdoc program, it was it was like 48% of all liver failures are due to one drug in the United States, and that's acetaminophen or Tylenol, right? And it's in lots and lots and lots of products. So by the time, it was 2012, so about 2015, I think, when I was updating some of my lecture material, it was to 52%. So 52% of all liver failures in the United States are due to one medication that is the most prescribed by physicians, especially for pain, which we don't even know the mechanism for pain. Tylenol is a completely synthetic medication derived from part of the pathway of willow bark. So they turn coal tar into this new drug that kind of works, but they're not sure why it works for pain. Now, for antipyretic for fevers, like it's good, but you also should not be lowering fevers. You need fever. So anything over 100.4 is your body shutting down the viral growth so it can then win this war because it can't outbreed a virus. So that being said, you will see Tylenol all the time, and they're just like, well, you can't take ibuprofen because it'll kill your kidneys. So you have to mix this up with some acetaminophen. So that way we're kind of like damage to the kidney, letting it heal for 3 hours. Damage to the liver, let that heal for 3 hours. Damage the kidney, and they just keep going on. Now, Newton, where I used to practice, little town, 50,000 people, 3 dialysis centers, right? So what is the consequence of chronic aspirin, ibuprofen, naproxen? Kidney failure. So with acetaminophen, they also found that it also damages the kidney. But the hydrocodone basically is our glorification of legal morphine. And so they're shutting it down through a little bit of different pathways there, more through your morphine receptors. Now, I don't know if you know this, but there's stuff growing in your yard that has morphine in there. And it's wild lettuce. Like it grows really tall, has little spiny looking, sparse little long leaves off that. But that's traditionally what they use for natural morphine for pain relief. So people are using gas station pain relievers like kratom and the synthetic kratom, which can be very beneficial. You should probably get them from more likely a head shop than a gas station, just to ensure better quality. I don't know if you've ever seen the tests online, but a lot of times it's not good. So you want to get someone at least where they're all about it, and they have a little bit better quality control and a little bit of accountability to the consumers, because you like Jerry at the gas station sells you something that doesn't work. I don't think he cares, right? But if somebody has a small mom and pop like head shop or something like that, or natural weed stores, you'll see that where it's legal, like they cultivate trust with their people. So they tend to be a little bit more knowledgeable and care about the quality. Kind of like some health food stores will have, like GNC, like they will have stuff that has no active ingredient and still leave it on the shelf. But places like natural grocers, they tend to scrutinize really well. So you always know you can have better trust with this. Not perfect, but then you're like, I don't know about this sketchy ass GNC store, right? So that being said, hydrocodone mixed with acetaminophen typically is the last ditch effort here. And so we're trying to regulate the opioid receptors at this point, which is totally different than the COX-1, COX-2, and the PLA2s. Again, still trying not to use straight up steroids with this. Now, non-opioid therapies, just so you know, are typically preferred for subacute and chronic pain. The CDC recommends maximizing appropriate non-pharmacological and non-opioid pharmaceutical treatments. But again, you only got a few minutes with the doc, so a lot of times it's just cracking that out. Before the big controversy of all the people that died from opioids, they were just like handing those out like candy. I had a client come in after all that controversy when they were really scrutinizing people, and he came in with a bottle for 90 days worth of Vicodin. And I was like, just for his first time with pain. And I was like, you're sitting on a gold mine if you're willing to go to jail. But also, like, who's this doctor giving out 90 days worth of opioids? Like, does he not watch the news? Does he know that the recommendations have kind of really tightened up about that? So, anyways, can't fix other people. So conventional is really just kind of management. Eventually, they'll start doing synthetic PLA2s, which is corticosteroid injections, usually for pain. The first one is like a miracle for them because they're out of pain, but it only lasts like 6 months. The second one, typically, that'll last like 3 months, then about a month, and then they typically stop working. Now, the problem with corticosteroids is when you inject it in there, the steroids actually damage and injure that joint and the tendons and the ligaments. So now you're worse, right? So it's like taking the fire alarm batteries out. So now I feel better, right? But the fire is still raging in there. And this is where the treatment often is worse than the chronic pain, because now you got to do surgery. So at least back surgery, probably knees and hips. I feel like people tend to get a lot better with those. Like, they do a good job. I don't know if you ever watched those. There's only been 2 times when I'm about to throw up in surgery rounds. One was the first sebaceous cyst I've ever seen. Did not expect that. And the second one was them scraping necrotic bone from a joint, and then he was hammering, like almost a little mini sledgehammer, this metal device into the bone. And I was just like, I'm not doing surgery. Like, this is too much. Like, this is super aggressive. Like, you think there's like a professional way to doing this, and it's brutal. So I feel like knees and hips tend to work very well. Patients tend to get better with those. But back surgery, typically the expectation is about 3% success rate of getting them into less pain. So it's only a job where you have a 97% failure. It's only rivals oncology for failure and getting paid the most. So I don't know. They should get paid for outcomes. Then I think it would change a little bit. So they might do like a chiroplasty or something like that, and inject chemicals inside the vertebral body, and then that's going to decay and break because you didn't fix anything. Or they fuse stuff, and then of course if you have limited motion here, now you have higher motion above and below. You wear those out faster, and now they're just having injury and chronic pain in above and below the fusions. So it's about a 97% success or failure rate for the spine. So that's where you really want to kind of go to the chiropractor, do physical therapy, decompression, go to your functional medicine doctor. Like, that's, I mean, if you're going to do back surgery, that'd be the last ditch option. But a lot of times people, that's the first option. So, all right, so you can't do the COX-1s very long, can't do the COX-2s, you can't do the hydrocodone or opioids very long, can't really do gabapentin, maybe gabapentin. I mean, you can have quality of life issues, but that may be better than the horrible, debilitating pain too. So long-term opioid, of course, use is not recommended for first-line treatment unless they have like bone cancer or something like that. So what do we do? What do we do with this person, right? 9 years of chronic pain, debilitating, quality of life has gone to crap. The dude's only 58 years old, and he's just going to be managed until he gets surgery, and that's probably not going to go very well. So what we do then, again, is our standard functional lifestyle medicine protocol. So we do an intake, figure out his whole lifestyle, everything from head to toe that's falling about. What are you eating, drinking, peeing, pooping, sleeping, stressing? Head to toe, tell me everything, right? And from there, we have our complete list of 30 to 60 to 90 things that are chronically going on with him. Then we do the food sensitivity. Now, chronic pain is a big component of like hyperhistamine or histamine overload. You have very specific pain or types of histamines from 1 to 9. And I can't remember what specific one, but it drives the pain response. So chronic histamines is chronic inflammation, and chronic inflammation takes up space, which then causes chronic pain. So by doing the food sensitivity test, we can figure out which foods his body is attacking as if they're pathogens, creating very specific histamines. Stop doing that. All of a sudden that histamine number goes all the way down, and suddenly his body's not chronically inflamed. Now the pain starts to go away. We make food changes, we make chemical changes, we make hormonal changes, and then we do our reevaluation. And his was, the final was 6 months, but his outcome, the pain decreased from a 7 out of 10 on opioids and gabapentin and ibuprofen. So it went from a 7 out of 10 to a 2 to 3 out of 10. And then the last one after 6 months was 0 out of 10. So sleeps better, he's walking, has exercise tolerance. Suddenly he can move and do things with his family. I think this one, they went to an amusement park. He's in a wheelchair at 58 with his family pushing him up and down. And he can't do much of anything, but he wanted to participate. But now he's walking at the amusement park. So totally different person. And on a personal note too, like a lot of the stuff we talk about is like our glorification, like, oh, well, we helped reverse all these things, right? But that person gets to be a different dad. That person gets to be a different son. That person gets to be a different husband. Like, you're not just getting rid of pain. You're not just getting rid of migraines and Crohn's and eczema. You are giving people back a version of their self that they have not seen in a long time. And I know one of our chronic pain people, he was just like, I mean, again, like years dealing with this, and then like 3 to 6 months, that dude's like pain-free. And he's like, I could have been this way through my child's school and through my marriage and through, my work. And like, I could have felt better this whole time. So most people don't even know that there's options. So our philosophy is always like, most people are just chronically suffering and dying prematurely based on what their current doctor doesn't know. And that's it. If they don't know how to fix stuff, you're just going to get managed. But that's a whole quality of life that's just not worth it. So Chronic pain, you will see people want to end it all because of that. It's too much. Like, you're just not the person you used to be. So, a grand round takeaway, chronic pain is not an endpoint. It's basically, what are we doing to cause it? And then it should extend beyond suppressing pain. So we don't want to do natural pain relief. We can switch to that in the beginning, but we don't want to do that very long. We want to fix, and we don't want to mask the problem. So that's nice when they taper off and they come off the medications, and you're just like, okay, now what's really going on now that we're not taking the batteries out of the fire alarm? And then, of course, his pain scores went to 0, improving movement, strength, and of course, quality of sleep, which is critical. His metabolic health is better. He's losing weight. A1C is getting better with that. And of course, functional and quality of life. So, pain's a big one, you guys. It really is. And I think that's a niche all on its own of being able to be like, really promoting a pain clinic, because holy crap, functional lifestyle medicine, that lifestyle approach to this is like life-saving, right? Life-affirming. All right, you guys, I hope you enjoyed that. Get these people out of pain. Next week, what are we doing? Let me see here. I think we have, oh yes, we have a really, really good one. This one, just to give you a little preamble here, or not a preamble, a preview. I think she's 17 and is a girl, and she had chronic pain syndrome. It's complex regional. It used to be called reflex dystrophy, and they get a new fancy name for it. But these people don't respond to any pain meds. Like, we did an amputation and surgery rounds for someone that had this. Like, that's how you get rid of this problem. And I want to say it's less than a month. Like, this was one of those cases where I started like really implementing the stuff I learned at Harvard and Yale for lifestyle medicine, and putting that together with my functional kind of medicine and diplomate stuff. And so I started seeing these really great, like, miracle patients, right? And this was one where I was just like, oh my God, I've never, like, I know this from medical school, from Grand Rounds. Like, I don't know, but I'm like, it should work. Like, I keep making all these people better. Like, this should work. And oh my gosh, this was probably one of those where I was just like, this is the shit. This is the best protocol in the world. I am like doing amazing work finally. But I went from like, oh my God, I'm not going to help this person, to, oh yeah, of course it's this easy, right? And then the mom was like, oh, they're going to call you. Yeah, these pain centers are going to call you, and I'm going to tell them that, after 5 years and every medication, blah, blah, blah. I was like, they ain't going to call me. Nobody cares what I do. The goal is not to fix anything, right? So the goal is to manage and get through volume so they can get their insurance. It's just a system that's just bastardized medicine for us, right? It wasn't always this way, but especially since AMA and all their changes, we created a whole different beast, which then allows us to do better work. So, all right, you guys, look forward to seeing you next Monday for Grand Rounds for that.